So hello and welcome back to my channel Dr. Happy Vagina. My name is Ida Bergman and I work as a pelvic floor surgeon in Sweden. And I have created this educational channel for my patients and for my colleagues, but actually also for the women all around the world. And in this video we will speak about how you should recover after a pelvic floor surgery. I will give you advice on pain management, on bowel function and on bladder function. We will speak about how much you can do physical activity and when you can start having sexual intercourse after your procedure. We will also speak about hygiene after your surgery and also about possible complications and when you should go to the emergency room or call your surgeon after your procedure. So here we have the urinary bladder, and under the urinary bladder we have the anterior vaginal wall. Here we have the vaginal opening, and here we have the posterior vaginal wall. Here we have the anus, and we have the rectum, the bowel, behind the posterior vaginal wall. And in the top of the vagina we usually have the cervix, if you are not hysterectomized, and we have the uterus. Around the vaginal opening we have the bulbocavernosus muscle, keeps the vagina closed, and we have the transverse perineal muscle that stabilizes the anal canal and also fixates the perineum to the skeleton, to the pelvic bones. And between the bladder and the anterior vaginal wall we have the pubocervical fascia that gives all the support to the anterior wall. And in the posterior vaginal wall we have the rectovaginal fascia, which is connective tissue that holds the bowel in place. And around the cervix and the uterus we have ligaments that holds the uterus and cervix in place. So if you lose the support for the bladder and the anterior vaginal wall, this will start to come down and bulge out of the vagina. And if you have this problem, you probably have undergone an anterior colporrhaphy procedure. And here the surgeon opens the vaginal mucosa and takes this connective tissue from the pubocervical fascia and merges it from the side like this to the middle. So you do it with sutures. So we want this connective tissue to scar together in the midline so that we will get a new support under the bladder. And this procedure, as I mentioned, it's called anterior colporrhaphy. Sometimes also the uterus and the cervix is coming down, and one of the correcting procedures might be that the surgeon does a cervical amputation. So we take away the cervix and we find these ligaments and we suture them to the remaining uterus body, and this will lift up the top of the vagina. And this procedure is called cervical amputation. There are also other procedures to correct this apical support. This is just one example. Maybe you had rectocele, which means that the posterior vaginal wall has loosened its support from the rectovaginal fascia, and then you have to correct this by doing a posterior colporrhaphy. And sometimes also the muscles around that are fixating in the perineal body are damaged from a vaginal birth, that they are ruptured or that they are distended. So sometimes the surgeon will also reconstruct the perineal body, take the muscles from the side and merge them together in the midline. And this one we call a perineorrhaphy. Perineorrhaphy. So you might have undergone one of these procedures. And first we will start to speak about pain management. So if you do an anterior colporrhaphy or a cervical amputation or another procedure in the top of the vagina, normally the pain is located in the lower abdomen, so you can feel this like your period pain. It can be quite intense, and some women feel nothing. So this is normally not a very painful procedure. But on the other hand, if you have done a procedure in the posterior wall and especially in the perineal area, the pain can be extremely severe. So it's more common to have severe pain if you are younger, maybe premenopausal, and in older women, severe pain is less common. And for all women, the basic pain management is usually that you take some kind of anti-inflammatory painkiller. One example is ibuprofen. And in Sweden, we can buy this 400 milligram. And you take 1 tablet every 8 hours. And you have to combine this with paracetamol. Which in Swedish pharmacies without prescription you can buy 500 milligrams, and of this you will take 2 tablets. So 2 tablets in one time, and you can take every 6 hours. So I normally advise my patient take 1 ibuprofen and combine it with 2 paracetamol taken in the same time every 8 hours when you are awake, and if you wake up in the night you can add another 2 tablets of paracetamol. And it's good to go to the pharmacy before your surgical day to buy this so you have it at home, because when you are newly operated on, you just want to go home, go into your bed and have everything prepared. Okay, and especially for women who do these posterior procedures, as I mentioned, the pain can be very severe, and sometimes we had to add also the first day some kind of morphine tablets. Morphine, and it can have different names, for example oxycodone, oxycontin, oxynorm. There can be Targinic or other kind of morphine tablets. And you take ibuprofen and paracetamol, and if it's not enough, you still have very severe pain, you cannot tolerate the pain, then you add morphine. So you don't take it routinely, because this morphine gives some side effects. And the negative side effects is nausea. So many women start to vomit, and they feel this nausea and vomit is actually worse than the pain. So you have to choose pain or vomiting. But not everybody will start to vomit, but this is a big problem for many women. Another problem is obstipation. Because we really want to avoid obstipation after reconstructive procedures, and we will speak about this later in this video. And the third thing is that morphine is a very good painkiller if you have a severe pain. But if you take morphine when you actually don't have so much pain, then you will get this morphine kick and euphoria, which is very addictive for the brain. So be very careful with your morphine. Stop the morphine immediately when you don't need it for the pain, because otherwise your brain can trick you and say, give me more, and you can start to develop an addiction if you take it when you don't need it. So this is usually the basic pain management, at least in my clinic. And I know that some clinics also use another pain relief that is called gabapentin. It's against nerve pain. So in our clinic we don't use it routinely, but if we have a patient with chronic pain from before, we can add gabapentin also to our pain management scheme. Or if a patient has a prolonged pain after her procedure. So normally the pain is reduced, goes away after 2 weeks. But if you have pain that persists maybe 3 or 4 weeks and doesn't get better, we usually also add this nerve painkiller, for example gabapentin. There are also other options, but this is one of them. Okay, and regarding ibuprofen, many patients get the side effect of having pain up here in the belly that we call gastritis, that your belly and your ventricle gets irritated. And if you know that you easily get this when you eat painkillers, you can from the beginning start with one medication that we called omeprazole. And in Sweden we can buy this without prescription, 20 milligram, and you take 1 tablet per day. And you can start before you start with your ibuprofen to keep the ventricle calm down, or you can start to use omeprazole if you feel that you are getting nauseous and you have pain in the upper abdomen. You can add omeprazole. Or if it's very severe, you have to stop your ibuprofen, but the ibuprofen is the best pain relief when you have done a surgery in your pelvic floor. So it's good if you can continue and rather use ibuprofen than morphine. Okay, so and one more tips about pain management, which is not about tablets, is that you can use an ice pad. So you take a little menstruation pad and you put it in the water, put this in your freezer and wait until it's cold, and then you can take it out and put it in a clean sock, for example, and put it against the perineal area, because this reduces, the cold reduces the swallowiness and also reduces the pain. And the last thing I want to mention is that you can buy a local anesthetic gel. You can also buy this without prescription in Sweden, and this, I will write up here, is called xylocaine. Xylocaine gel. And you can apply this on the perineal area, which reduces the local pain. So this is my tips for the pain management. So the next thing we will speak about is bowel emptying after your procedure. So you should really avoid getting constipated when you do this kind of procedure, because if you have to, we have the intra-abdominal space here, and if we increase the pressure inside the abdomen, we will have a lot of pressure on this surgical area. And as I mentioned, we take these muscles and connective tissue and we want to merge them together when we don't want anything pushing in this area. We want this optimal healing. And if you go to the toilet, you are constipated and you try to squeeze, you will have a lot of pressure on this area that makes the healing not as optimal as it could be. And I recommend my patient that they go to the pharmacy and buy laxatives before their surgical day, so they know that the bowel is moving and that the stool is soft. And they can also try what is the best laxative for me and what is the optimal dose for me, because our bowels are very different. There is not one dosage or solution that fits all. My favorite in Sweden, I don't know what you have in other countries, but we use Movicol, which is a powder that you mix in water. And the normal dose, it's 1 to 3 bags per day. But some women only take a half bag and some need even 4. So it's individual, but you can try out this before your procedure. And you should not have diarrhea, that it's only running like water. It should be stool, but easy and soft and easy to squeeze out. Okay, and many of my patients ask me if they are constipated and we have done this surgery, can they use this kind of local tubes that, for example, Microlax, that you put inside the anal canal, and that makes this stool that is located here come out. And normally you don't have to use it if you use your Movicol, because in 1 or 2 days this Movicol will help you pass your stool. But if you feel that it's very acute, you have a big stool here that is it's not coming out, then it's okay to use Microlax. It's not gonna harm anything. But we usually don't recommend it routinely. And other tips to emptying your bowel is when you go to the toilet, you use a little chair underneath your feet so that you come in this squatting position. So as women, we shouldn't sit like in 90-degree angle like this on the toilet. This is not optimal bowel movement position. We should put a little chair under our feet so that the knees come up. Here is the little chair. So we are in a squatting position, because this makes the puborectalis muscle to relax, and it's more easy. The bowel will get more straight, and it's more easy to empty the bowel. And also another tip is to take some paper in your hand and push this paper against your perineum so that you will get extra support when you push little and try to evacuate your stool. And if you feel like you have to push too hard, then stop it, go away from the toilet and wait until you really feel that you have to go, and then you go back and you try again. Next thing we will speak about is peeing, or the bladder. And the first thing I want to tell you is that the surgeon, when we do this procedure, we put a lot of local anesthesia in this area. And this local anesthesia will affect this nerve called the pudendal nerve that goes into the pelvic floor to this surgical area, but it also gives branches to the urinary bladder. So when the local anesthesia is still affecting, then it can be difficult to have the normal pee reflex. So when you go to the toilet, you sit, you try to relax, then your pee bladder is not starting to squeeze out the pee. It's not coming out. And also, if it's you can have some edema or swallowness in this surgical area. This can also compress the urethra so much that it's difficult to pee during the first day. And sometimes we have women that cannot pee when it's time to go home, when we close the clinic, and we put in a catheter like this in the pee bladder, and then you come the next day and we remove this catheter when all this swallowiness and local anesthesia has gone down. And almost all the women can pee the next day. And it's very important, if you come home and you feel that the pee is not coming out, you cannot pee. You have to go back to the healthcare provider, because if you have more than 1 liter of urine in your pee bladder and you cannot get it out, you can get damaged in your pee bladder. So it's very important that you come back to the hospital or your clinic if you cannot pee when you come home. And another thing I want to say about peeing is that especially when you do surgery here, close to the bladder and urethra, we usually say that 30% get better. So if you have, for example, an overactive bladder, or it's difficult to hold urine, or it's difficult to evacuate urine, 30%, if you do anterior prolapse surgery, will get better. 30% will stay the same, nothing happens. And 30% can get even worse. And we don't know this beforehand, which women will get better and which women will not. So you can, the women that gets worse can get more overactive bladder symptoms. And we know that approximately 10% that didn't have problems before get problems with holding the urine when you do physical activity. This is called stress urinary incontinence. So when you cough or you laugh or you carry something or you do physical activity, you will start to lose urine. You cannot hold it. You get incontinence symptoms. And I hope your doctor has told you about this, that this can happen after an anterior wall prolapse procedure. Okay, and when we do surgery in the back wall, it usually doesn't affect the pee bladder. Sometimes when you do the reconstruction of the muscles, you can get more support around your urethra, and you can get less symptoms of urinary incontinence. So usually if something happens, it normally improves when you do surgery in the back wall. So this was about peeing. Okay, so now we will speak about physical activity and intercourse after a prolapse or reconstructive procedure. So we know that these fascia structures, or the muscles that we reconstruct, it takes minimum 6 weeks for them to heal and get a good strength. So you should avoid everything that gives pressure to this area during the first 6 weeks. So you shouldn't carry heavy things. And what is heavy? Approximately 10 to 15 kilo is heavy lifting. You should not run or jump or go to the gym or do anything that stresses this area. Minimum 6 weeks. It has very good strength after 12 weeks. So after 12 weeks, you can do basically what you want. And this is the same thing with intercourse. In our leaflets, usually we say you should wait 8 weeks, but my clinical experience from seeing hundreds of women after their surgeries, and I ask about when did they start intercourse and how was that? Usually if you start 8 weeks, it's too early, it's painful. The man can feel some stitches coming up here, pinching the penis, and 8 weeks is a little early in my opinion. Usually I recommend my patients to wait 12 weeks. And when they have intercourse the first time, it can feel different, so the sensation can be reduced. It can feel a little irritated and scary in this area. And yes, you can have a little pain in the beginning. But you don't have to get panic of this if you feel like that the first time. Usually up to 1 year it takes for scar tissue to remodulate and be more soft and loose. And it takes up to 1 year before all the muscles and the nerves and everything is really completely healed. So you have to have patience with this procedure before you can evaluate where it ends, where is how it will be long term. But intercourse, minimum 8 weeks, but normally 12 weeks is better to not have a bad experience. But nothing will break if you have intercourse after 8 weeks. You cannot damage anything. Okay? And when you come home, it's okay to do normal activities in your home. You can cook, you can go to the toilet, you can take small walks the first day. This will not, it's only good that you are moving. This reduces the risk of blood clots and other complications. You should not lie in the bed for many days. Normally the first day you have pain, you are tired, of course you will sleep and you will rest. But after, try to go up to the toilet and do little movements and not only be still in your bed. Okay, and then we will speak about the healing and the sutures and hygiene, how you should take care of your hygiene. So it's completely fine to take a shower from the first day, and we recommend that you shower this area at least 1 time in the day with normal tap water. You don't have to use disinfection or some kind of soap. You can just use clean water. And if you go to the toilet to do number 2, you get stool around this area, you should go and clean that with clean water. You should not go in a pool or in a bathtub until the wound is healed, because in pools and in bathtubs we have a lot of bacteria, and this will increase your risk of infection. So I would say wait at least 4 weeks until you take a bath in the bathtub or in the pool. But shower is completely fine. Okay, and the stitches, we have some stitches in the skin. These normally go away after 2 to 4 weeks. 2 to 4 weeks, they will go away quickly. But the stitches that are more deep in the muscle and in the connective tissue, some of the surgeons use stitches that remain for 180 days. Okay, so it takes a long time before all the stitches are completely, every molecule is completely gone. And many women who use local estrogens, they are asking, when can I start to use my local estrogens again? Because this you put inside the vagina. And this is the same thing. You should wait until the superficial wounds are healed. And you cannot see that inside the vagina, of course. But after 4 weeks, you will be on the safe side. So if you wait 4 weeks with local estrogens, you will be on the safe side. Okay, and the last thing we will speak about, when should you seek acute emergency medical care after this procedure? We already spoke about if you have problems with bladder emptying, you should go directly to the hospital. Another thing that can happen when you come home, that you get bleeding. So when we put this local anesthesia in the surgical area, we use usually local anesthesia with adrenaline, and this adrenaline makes your blood vessels close like that, and it's more easy for the surgeon to do surgery. It's not bleeding too much, and we close the wound and we inspect, everything is good, there is no excessive bleeding, and we are happy. But after a few hours, this local anesthesia will go away, and also the adrenaline effect will go away, and this can make some of the blood vessels relax, and a bleeding that we didn't see in the operating room will now start to bleed after. And this you will see that it's not only small amounts, because it's normal to have small amounts of blood on the pad after the surgery. Maybe for 1 to 2 weeks you will have some kind of blood or secretion from this area. But if you have a big bleeding that's coming, fresh blood coming and not stopping, then you have too much blood, you have to go back to the hospital. It's not dangerous. We will manage this with putting an extra little stitch and everything will be fine. But it's good to be mentally prepared that this can happen. And the last, maybe the most common complication is wound infection. So even if you would give prophylactic antibiotics, it means that you take antibiotics on your operating day, you still have a 5% risk to get an infection in the surgical area. Or you can get a UTI, because sometimes we use a urinary catheter in the bladder when we do this procedure, and this increases the risk of a UTI, a urinary tract infection. But if you get a wound infection, the first sign of an infection is increasing pain. So like I said, the pain should be stable and go down for every day. Normally, the infection comes after 3, 4, 5, or 7 days after your surgery. So if the pain is going up, even if you use your painkillers, it's a sign of an infection. So you shouldn't wait for fever, you shouldn't wait for foul discharge, you should go, if the pain goes up, you should go to the emergency room or call your doctor and ask for an acute appointment. Because if you have an infection that is not early treated with antibiotics, the whole surgical area can rupture, and we cannot suture again an infected, ruptured wound. We have to let it secondarily heal, and then sometimes we have to do the procedure again when the infection has cooled down. So if you get more pain, come to the doctor, we give you antibiotics, normally everything will be fine. If you wait too long and you don't get these antibiotics, in worst case, your wound can rupture. So this is very important. If the pain goes in the wrong directions, you have to do something. Okay, so this was all I wanted to share with you in this video. And if you have done some kind of pelvic floor procedure and you have some other advice that you want to share to other patients, please write a comment. Maybe, I'm sure there is something that I forgot to say. So let's share with each other our knowledge and our experiences. And yes, This was all for today, and I see you next week with more educational videos. Remember to subscribe to the channel, because 2-3 times or 1 time per week I will release a new video for you. Okay, bye bye, have an amazing day.